Assalamu alaikum. I am Dr. Muhammad Ali Rabbani, Assistant Professor Anatomy, and today I will be your guide for the topic of Gross Anatomy of Larynx. This is a lecture in the series of the crash course in which we have been discussing the gross anatomy of head and neck. This is basically the part 2 of the lecture that we started. The previous one, it was nose, paranasal sinuses and larynx. So we ended the previous video at nose and paranasal sinuses, and now this video we will start with the topic of larynx. We will study all of its structure. We will start with its overall skeletal structure, and then we will go on to the membranes, the structure, the folds, and the muscles, and then we will end with the lesions. Larynx. Larynx is basically the respiratory organ that is present between the trachea and the pharynx. We have yet to discuss the gross anatomy of the pharynx. So, in this is a very beautiful picture from the Gray's Anatomy. Here, this is the oral cavity. On the top of it, in the blue, it is shown the nasal cavity. On the back in the green, there is the pharyngeal cavity. The one that is behind the nose, that is nasopharynx. The behind the oral cavity is the oropharynx, and behind the larynx is the laryngopharynx. And in front of it, the outpouching, the branching occurs in front of it. This is the larynx. This is the opening that is opening back into the oropharynx, that is opening back into the laryngopharynx, and behind there is the major larynx, and it continues down into the trachea and onto the lungs and onto the lower respiratory tract. It is present behind the hide bone. The hide bone, when this is not exactly anatomical position, horizontal picture, it's a picture a little from above. When you're looking horizontally, the hide bone it's roughly at the level of C3. That is the level of the epiglottis also. Because we are looking from the above, we are not seeing them as the horizontal plane. Below, this is the cricoid cartilage that is lower, and that is at the level of C6. The thyroid cartilage, this is at the level of C4. So usually we talk about the larynx as lying between the C4 and C6. We are usually talking about the upper end of the thyroid cartilage to the lower end of the cricoid cartilage, and if we include the upper end of the epiglottis, we will be going up to the C3. The larynx, the major function of the larynx is the phonation. I'm talking to you right now, I'm recording this video. The sound that is coming is from the larynx. The second very important function is to function as the gateway of the airway, at least gateway of the airway as it becomes isolated. From the top you can see there is a part of the airway that is the nasal cavity, and the pharynx was a shared space that was shared between the digestive system and the respiratory system, and then it is larynx is the pathway, the gateway for the lower respiratory tract, to be more clear, and it is the sphincter for air passages. It protects the airway from the food and water and drink that is going through the pharynx. If it diverts to the larynx, it is stopped by it. The skeletal structure of the larynx. The larynx consists of cartilages and the membranes, and these will be the structures that we are going to be discussing now. Let me set up a few things. So the larynx, it consists of cartilages. These cartilages are six named cartilages. Three of them are unpaired and three of them are paired. And it consists of membranes. These are extrinsic membranes that are joining the larynx to the external structure, that include like thyroid membrane, hyoepiglottic membrane, then there is cricotracheal membrane, cricoid and trachea, and then thyroepiglottic. These are from the thyroid cartilage to the epiglottis. So these are extrinsic and intrinsic, consist of two membranes. These are quadrilateral membrane and cricothyroid and cricovocal membranes. So we will be going into the detail. Let me set up the 3D model. Okay, so here we are. So this is the skeleton of the larynx. It is made up of three unpaired bones. Let's look at them first. This large bone, this large cartilage that is making most of the outer covering of the larynx, this is thyroid cartilage. This is the anatomical position of the larynx. Let me get it a little straightened up. Okay, let me reset it. Give me a second again. Back to it. So this is the first unpaired cartilage, thyroid cartilage. This is a big one. You can see it from either side. It is covering the outside of the most of the larynx. We will go into the detail. The second one is this cricoid cartilage. This is the cricoid cartilage. It is again a single cartilage. It is forming a whole ring. Actually, interesting thing is that it is the only complete ring of the respiratory tract. Below it, the tracheal rings are C-shaped. Above it, thyroid cartilage is not covering from either side. Cricoid cartilage is the one that is a complete ring. And then we have this epiglottis. We have epiglottis. These are the three cartilages that are unpaired. Then let's look at the paired cartilages. These are here. Okay, let us look at here. So there are three pair of cartilages. You can all see three of them here. This is a pair of arytenoid cartilage. These are triangular shaped cartilages. These are arytenoid cartilages. On the top of the arytenoid cartilages, here are the corniculate cartilages. They are present on the top of the arytenoid cartilages. This one and this one. These are corniculate cartilages. Not attached with the rest of the cartilaginous skeleton. This is cuneiform cartilage. These are present in this membrane, that is quadrangular membrane, membrana quadrangularis. We will be discussing it shortly. So these are the cartilages that are present here. Thyroid cartilage unpaired, cricoid cartilage that was unpaired, then there was epiglottis that was unpaired, then three paired cartilages. There is arytenoid cartilage, corniculate cartilage, and a pair of cuneiform cartilages. So these are the cartilages. To talk about the membranes, so there are two sets of intrinsic membranes. This is the one we will be talking about, quadrangular membrane on either side, and then we will be talking about this membrane. This is cricothyroid. It has further two parts. We will be talking about anterior and lateral parts. This is the anterior part. This is going from cricoid to thyroid cartilage, and its inner aspect is going all the way to the vocal cords. So this is also known as cricovocal ligament. And there are ligaments that are connecting to the outside, like thyroid cartilage to the hyoid bone, thyroid membrane, its midline part, median thyroid ligament, and if we look from the outside, the ligaments that is joining hyoid bone to the epiglottis, and the ligament that is joining, it is counted as the extrinsic ligament, the ligament that is joining thyroid cartilage with the epiglottis. So these are the ligaments that we will be discussing, and of course there is this cartilage also, the cartilage that is joining the cricoid cartilage with the trachea below. So it is a complete ring of cartilage. This is complete ring of membrane that is joining these two structures. So these are the membranes and the cartilages that are forming the skeleton. So this is the overview of the skeleton of the cartilage. And then there is a thing about their histology. The thyroid, cricoid, and especially the upper half of the arytenoid, these are haline cartilages, at least partially arytenoid. Epiglottis, corniculate, and cuneiform. I'm sorry, this is the lower end of the arytenoid. Thyroid, cricoid, and lower end of the arytenoid, these are haline cartilages. And the epiglottis, corniculate, cuneiform, and maybe the upper part of arytenoids, these are elastic fibrocartilages. Thyroid cartilage. Let us talk about it here on the 3D model, then we will revise there also. Let us isolate it. This is the thyroid cartilage. Thyroid cartilage consists of two large surfaces. These are the lamina. This whole plate is the lamina of the thyroid cartilage, and on the lamina, on the anterior aspect, the border where the two lamina meet, this line is known as anterior border or median angle. This line is the median angle, and on the top of the median angle, this point, this point is known as thyroid notch, superior thyroid notch. This part that is on the top of it. In males, in genetic males, you can see this median thyroid angle, this hanging out outside the neck. The males, the genetic males who have matured sexually, usually they have this prominence, the thyroid cartilage, this median angle, laryngeal prominence. This is known as Adam's apple. Adam's apple is not so much a medical term. Median median angle laryngeal prominence is the angle name, the thyroid notch. The posterior border, if we look at it, it consists of two raised area. The horn that is raised above, the horn that is raised below. These are known as superior and inferior horns respectively. And then if we look at it, the inferior horns are the one that are responsible for making the joint with the cricoid cartilage. These will have articular facet on the interior aspect. These will be responsible for making a joint with the cricoid cartilage for the cricothyroid joint. And then we are left with this line. This line that is going, this is known as the oblique line, oblique ridge, and on both the ends, on the both ends of the oblique ridge, there is a raised area here and there is a raised area here. Both will be known as tubercles of the oblique line. So this is about the thyroid cartilage. Just let me set one thing. So this is about the thyroid cartilage. We have talked about this lamina, anterior border, superior notch, also known as laryngeal prominence or Adam's apple. It is due to the story of the Adams and Eve. They have said that the apple was stuck here. That is why the males have a prominence right here. There is a posterior border with superior horn, inferior horn, and there is an oblique line with the inferior and superior thyroid tubercles. This is the Adam's apple. The cricoid cartilage, it's a signet shaped ring. Let us look at it here in the 3D model. This is the cricoid cartilage, this one. If we isolate it from others, this is like a signet ring. It has the posterior part that is raised and anterior part that is called lamina. It is forming the foundation of the larynx. It is forming the base of the larynx. It will have the place for two joints on its sides. It will have a placement for the articular surface for the joining of the inferior horn of the thyroid, and on the superior aspect it will have a surface for the arytenoid cartilages. These will be placed on the top of it, so it will have a placement for that. On the posterior surface there will be two foci like here and here, and between them there is a median ridge, and they will be giving rise to the muscles, posterior cricoarytenoid muscles. We will discuss them as we reach the muscles. And then there is a ring, there is a lamina that will form the ring around the rest of the cartilage. This is the cricoid cartilage. Talked about the foundation of the larynx, signet shape, only complete ring in the respiratory pathway. The lamina is the posterior expanded part. The anterior arch is the arch. The lamina has the articular surfaces on the top, arytenoid cartilages on the side for the cricoarytenoid. On the back, there is a median ridge with fossa on the either side for the posterior cricoarytenoid muscles. So this is about the cricoid cartilage. Then there is epiglottis. It is a curved leaf-shaped structure, and it is a attachment. It is relatively freely hanging. I'm talking relatively because it has a lot of attachments. It has does not attach to the skeleton with each side. It is only attached to the skeleton of the larynx through this ligament that is known as thyroepiglottic ligament, and it is attached on each side to the it is attached to the hide bone to the front, and it has a lateral attachments to the hide bone also. So these are known as hyoepiglottic ligament. If I isolate this ligament, is this muscle, this not muscle, this cartilage, this is a leaf shape. This surface that is on the anterior aspect that is directed towards the oral cavity, that will be the oral surface, and the one that is on the back side, that is the laryngeal surface. And larynx, it has a tendency to fall back onto the larynx when you are swallowing, and it acts as the gatekeeper. It acts as the lid of the larynx. When you are swallowing, it goes back, it covers the laryngeal inlet, and it uh, protects any food particle from coming inside. This is about the epiglottis. And posterior surface is pitted as compared to the anterior surface, and the anterior surface has the epithelium that covered by epithelium that is similar to the oral cavity, and posterior surface has an epithelium that is similar to the respiratory pathway. We will discuss that. There is a catch in that. It is not complete information. In the midline, it is connected to the base of the tongue with median glossoepiglottic folds, and on the lateral aspect it has the lateral glossoepiglottic folds, and in between them there are fossae known as vallicula. Again, we will discuss them again when we will be discussing the interior of the larynx with the with the membranes. Arytenoid cartilage, it's a pyramid shaped cartilage. It is a three-sided pyramid. Its inferior surface is the one that is lying on the top of the cricoid cartilage. It will have three projections: the one that is on the top apex, the one that is on the anterior aspect, and the one that is raised on the posterolateral aspect. This one, the one that is on the top, that is known as apex. It gives the placement place for the corniculate cartilage. It gives placement for the corniculate cartilage, and the one that is this is the arytenoid cartilage. This is the lateral process, posterolateral process. It will give attachment to a muscle, set of muscles. We will discuss them. And this will have this anterior point. You can see this point. This is the vocal ligament, as it is giving attachment to the vocal ligament in front of it. So it has three surfaces. The one surface that is on the back, you can see. The one surface that is on the medial surface. There is a lateral surface right here. These are the surfaces, and the one that is inferiorly, that is helping in making of the joint. So this is about arytenoid cartilage. This is the isolated right arytenoid cartilage. The inferior, the apex, the vocal ligament, the posterior surface, the lateral surface, the medial surface, and the inferior surface that is forming the joint. So this is about the arytenoid cartilages. On the lateral surface, it will have depressions. The one above, it will be for the vestibular ligament, and the one below, that will be for the vocal ligament. Corniculate and cuneiform cartilages. These cartilages are present. These are very small. These are present on the top of the arytenoid cartilages. The ones The ones on the top of the arytenoid cartilages are known as corniculate, and the ones that are actually embedded in the membranes, these ones, these are for known as cuneiform cartilages. So they are shown right here and right here. So these are corniculate and cuneiform cartilages. This is all about the skeleton. The joints. There are two joints that are important to discuss. There is cricothyroid joint. It is present between the lateral surface of the lamina of the cricoid cartilage and the inferior horn of the cricoid cartilage of the thyroid cartilage. These help the thyroid cartilage of the larynx. If this is the cricoid cartilage, this is the thyroid cartilage. It helps thyroid cartilage to tilt on the top of the cricoid cartilage. And if you can see, this is the thyroid cartilage, this is the arytenoid cartilage. This tilting helps change the distance between the arytenoid cartilage and the median angle of the thyroid cartilage. In other words, it is changing the length of the vocal ligament. It is changing its length. When it is tilted forward, the distance between them increases and it becomes longer, and when it come back, becomes more vertical, the distance becomes smaller and it becomes less dense. The articular surfaces are on the medial aspect of the inferior horn and on the lateral aspect of the lamina of the cricoid joint, and the axis along with its movement, the axis will be the horizontal axis that is crossing between the two bones. It will be crossing like this from one cricoid cartilage, cricothyroid joint to the next one. And if we look at the path of the recurrent laryngeal nerve, this is a question that is asked in the examination. This nerve passes behind the cricothyroid joint before it supplies most of the muscles of the larynx. It actually supplies all of the muscles of the larynx except one muscle. So it is passing behind this joint, recurrent laryngeal nerve. The second joint that is to be discussed is between the cricoid cartilage and the arytenoid cartilage placed on the top of it. There are two surfaces, the upper surface on the lamina of the cricoid and the lower surface on the cricoid arytenoid. These two surfaces are articulating with one another. It is a synovial joint and it allows for two types of movement. One movement is that the whole of the arytenoid cartilage, it slides outside. It just slides outside. When it slides outside, the whole of the arytenoid cartilage slides outside and you see the distance increasing between them, and it leads to the opening. This opening between the vocal cords in front and arytenoid cartilages in back, this space, this space is known as glottis. So when they slide, you will see the glottis open as a V shape. You will see open as a V shape. The other thing is that the arytenoid cartilage, they remain on the top. If there is a cricoid cartilage here, tip here, the arytenoid cartilage, the one I talked about, they were sliding outside. The other possibility is that along the vertical axis, they don't slide, they rotate outside, the anterior surface going laterally and the posterior surface going medially. They rotate outwards, staying on the same point. So this is the situation. This is the rotation. This is the other movement that is possible here. When it rotates here, the glottis, it becomes diamond shape. It becomes diamond shape. So there are two possible movements of the arytenoid cartilages, and both of them are asked from you. In humans, the major, the way in which it is this one. The sliding is more important in humans, and the V-shape opening of the vocal cords, it's more prevalent in humans. Let's talk about the ligaments and membranes. The outer ligaments that were present we discussed, they were thyroid, cricotracheal, hyoepiglottic, and thyroepiglottic. Let's look at the thyroid membrane. It is attached between the thyroid cartilage below and the hide bone above. So here in the 3D model, you can see it right here. It is attached between the two bones, and this attachment, this attachment allows the larynx to work as a single unit with the head, hide bone. For the lectures we have covered so far in the muscles of the larynx, we have seen that the muscles that were elevating the hide bone, in their function it was written that there are elevators of the larynx. So that's how they are elevators of the larynx, because when any muscle elevates the hide bone, it elevates the thyroid cartilage and hence the larynx itself with it. So these are connected with that. There is an opening on the side that allows for the arteries and nerves that are going to the inside of the larynx. We will discuss them with the vascular supply. This is a question that is asked. What are the structures that are piercing the thyroid membrane? That mostly includes the internal laryngeal nerve and superior laryngeal artery and the accompanying vein. We will discuss them as we will be talking about the arteries. And it is forming the lateral wall of the piriform recess. So let us talk about that, the piriform recess. So the picture that I'm going to show now, it's basically the sagittal section of the through the larynx. So here is the epiglottis cut in half. This one. Here is the thyroid cartilage cut in half. On each side, they are covered by membranes. So this is the thyroid membrane that we talked about. The thyroid membrane, it is making the lateral boundary of the piriform fossa. The pharynx, in this particular picture, we are only looking at the laryngopharynx. In the laryngopharynx, there is a space, there is a depression. You can see this depression. If I add a line, let me add a line here, like here. You can see it is very deep. It is a depressed line. You see, it is inside. It is going like this. It is a depression. This line was going inside. So this tip is called piriform fossa. This piriform fossa, if I remove this membrane, let me remove this membrane. This is the mucosa. If I hide this piriform fossa on the medial aspect, it is being covered by this membrane. This is the quadrangular membrane. On the lateral aspect, it is bounded by the thyroid membrane. So thyroid membrane, when talking about this, we said that they are forming the lateral wall of the thyroid membrane. So this is about the thyroid membrane. We talked about the attachments, the lateral wall of the piriform recess, and it is perforated by internal laryngeal nerve and superior laryngeal vessels, arteries and veins. This is about the thyroid cartilage. Its anterior membrane part is called median thyroid ligament. Then there is epiglottis. Epiglottis, two ligaments are important. We have seen them multiple times in the model now. The ligament that is joining the epiglottis to the thyroid cartilage, this is known as thyroepiglottic ligament. And the ligament that is attaching the anterior surface of the thyroid cartilage to the posterior surface of the hyoid bone, that is known as hyoepiglottic ligament. So these are the ligaments. Let me talk about a structure that is vallecula. Let me get back. Let me set up a few things. Give me 1 second. One more. Okay. No, no, no. I have to set up one more thing. The 3D model that I'm going to show now, it will be focusing on the posterior aspect of the larynx. So don't be confused by a lot of the things that you'll be seeing. Let's keep our focus. So this is the larynx, the laryngeal inlet. On the side, this whole ring, this is the laryngeal inlet. The epiglottis on the top, the arytenoid cartilages with the Corniculate cartilage is here, and in between them there is the airy epiglottic fold running between arytenoid cartilage and epiglottis. On the top, this is the tongue. This is the tongue, mucosa of the tongue you are seeing. This is the posterior one third of the tongue that is shown with a lot of uh, lobulations, and on the top, this will be the anterior two third. This is the junction between them. Here, between the tongue and the this space, this tip, this is called vallecula. This space between the epiglottis behind and the tongue in front. Epiglottis behind and tongue in front. This space is called vallecula. This is a dip that is present between the two. In this particular model, the one thing that is missing here is a fold that is present between the epiglottis behind and the midline of the tongue in front. So it is dividing the vallecula into two spaces on the each side. These are divided by the median glossoepiglottic fold that is not shown here very nicely. That is medial glossoepiglottic fold. So this is about the laryngeal, this is about the ligaments of the larynx, and this was the vallecula that we were seeing, and there is the median glossoepiglottic fold and the lateral glossoepiglottic fold. They make the cavities on the either side of the back of the tongue. Then we are left with intrinsic ligaments. No, extrinsic ligament, the last one. The cricotracheal ligament, it's very simple. It is present between the cricoid cartilage and the trachea below. We usually do cricothyroidotomy between the cricoid cartilage and the thyroid cartilage here in this ligament, but sometimes this is also used, but again, not so much. Let's talk about the quadrangular ligament. This is a tricky concept. I will try to go back to the model and set up a few things. Let us talk about the quadrangular membrane. So this is a section. The thyroid cartilage has been cut, and you are seeing the ligaments. So this ligament, we have to get a few things now like this. This ligament, this one, this is the quadrangular membrane, quadrangular ligament. You check what are the attachments. Anteriorly, it is attached all the way to the epiglottis. It is attached to the lateral margin of the epiglottis. Simple. If we look at posteriorly, it is going downwards in the inner aspect of the thyroid cartilage. And here again, I'm going to remind you that here it is making the medial wall of the piriform fossa that we saw earlier, and it is ending here in the free margin. In the lower aspect, it has two attachments: the attachment to the back to the arytenoid cartilage, the attachment to the front to the thyroid cartilage. So between the two, this free lower margin of the quadrangular membrane, this is called vestibular ligament. This is called vestibular ligament, and they make the false vocal cords. So this is the quadrangular membrane, and let us see right here in this pictures on the Grace Atlas also. So here is the quadrangular membrane shown attached. Let's just focus on this picture first. It's a fibroelastic membrane. It is attached anteriorly to the whole of the epiglottis. Posteriorly, it is attached to the arytenoid cartilage, and lower end is attached to the arytenoid cartilage here and the thyroid cartilage here. And in between them, this free hanging margin, this is known as vestibular fold, the false vocal cords. So when you're looking at the atlas, let me remove myself. When you're looking at the atlas, you will have to see a lot of pictures in different views to get an idea. Here, the anterior attachments are indicated, but the inferior margins are very clearly shown, the vestibular fold. Here, this anterior attachment across the epiglottis, anterior attachment across the epiglottis is shown. A gap is cut to show through it. Here you are seeing the lower attachment posteriorly to the arytenoid cartilage, anteriorly to thyroid cartilage. This free hanging margin, this is the vestibular ligament. And here it is shown with the mucous membranes. So this is the quadrangular ligament. So this is all the things that are written. Fibroelastic extent we have discussed. Anteriorly lower half of the epiglottis, posterior borderly arytenoid cartilage, lower border is the vestibular ligament false vocal cords, and it is defining the laryngeal inlet. This line is the laryngeal inlet. Anteriorly, the epiglottis on the aspect, the mucosa covering the quadrangular membrane that is known as airy epiglottic fold between the airy retinoid epiglottis, airy epiglottic fold, and in between them, then the tip of the arytenoids, including both of the cuneiform and corniculate tubercles, and then there is a mucosa that is joining both of the arytenoids, that is interarytenoid notch. This is the laryngeal inlet. This is the laryngeal inlet, and this is how you can see it from the top. When you see from the laryngoscope from the top, you can see the quadrangular membrane going from the outside to inside as it moves down. So this is how you will see the quadrangular membrane. So this is the quadrangular membrane, and just a quick review on the 3D model again. This is the quadrangular membrane. Between attachment is anteriorly the epiglottis, posteriorly to the arytenoid cartilages, and lower end is attached anteriorly to the thyroid cartilage and posteriorly to the arytenoid cartilage, giving rise to the floor free margin that is known as vestibular ligament. It is housing the corniculate cartilage and the cuneiform cartilages, and it is making the laryngeal inlet. So it is making a part of the laryngeal inlet that is right here. So this will be the laryngeal inlet. Anteriorly it will be made up of the arytenoid, epiglottis, then quadrangular membrane, then arytenoid, and then the part joining between them. And it is forming the lateral wall of the piriform fossa. It is making the lateral wall of the piriform fossa, as can be seen right here. So this part that is between the two, it is between the quadrangular membrane and the thyroid membrane above, and quadrangular membrane and the thyroid cartilage below. This is the piriform fossa. The food actually slides across here. The food does not come on the top of the larynx here. This does not happen. The food slides from each of the sides of the larynx. The food comes either side of the larynx through the piriform fossa back into the esophagus. And this is where the food gets stuck. The things get stuck. Then there is cricothyroid ligament going back. Cricothyroid ligament, as the name indicates, it should be very simple, that it is attached to the cricoid ligament and it is attached to the thyroid bone ligament. It is attached below to the cricoid cartilage and above to the thyroid. As the name indicates, it should be very simple, and it is for the part that is near the midline. This particular part, it's called median. This particular part is called median. When there is an N in the end, it means in the midline. Cricothyroid ligament. It's very simple, attached to the cricoid in the midline in front, attached to the thyroid cartilage above. The one that gives you a tough time is this one. It is named as the cricothyroid ligament. It is attached to the cricoid ligament cartilage below, but it does not get attached to the thyroid cartilage above. It does not. If you look at it, oops. Okay. If you look at it from the aspect, you see it is going up inside the thyroid cartilage. This is the margin of the thyroid cartilage. It is not attaching to it. It is going from the, like this. It is going from the inner aspect up inside. Let us look from this view. So see, from here we can see how it is going up inside the thyroid cartilage without actually attaching to it. It is turning inside. It is turning inside, going in the inner aspect of the thyroid cartilage and going up. It is going up. Just like we talked about the inferior margin of the quadrangular membrane, here is the similar situation. The upper end of this ligament, the upper end of this ligament, anteriorly it is attached to the thyroid cartilage, the midline, the median angle, and posteriorly it is attached to the arytenoid cartilage in the anterior process that was known as vocal process. And you may have guessed it by now, the upper free margin of the cartilage, upper free margin of this membrane that is running between the thyroid cartilage anteriorly and the anterior muscular process, anterior vocal process of the arytenoid cartilage. This is the vocal ligament. This is the vocal cord. This is what is producing my sound right now. This is vocal ligament. So that is why the part of the cricoid cartilage, the part of the thyrocricoid ligament, the part of the thyrocricoid membrane that is lateral, that is lateral. It is actually running from the cricoid cartilage below to the vocal cords above. So it is known as cricovocal membrane. So the lateral cricothyroid, it's better known as cricovocal membrane. It is running between the cricoid cartilage here and the vocal ligaments right here. So it is cricovocal membrane. So it has two attachments. They are seen. We are here back to this part. So the anterior part, it's running from the cricoid to thyroid, the one we saw here, median, or the median cricothyroid part, and the lateral part it's going cricoid deep to the thyroid, the vocal cord. So it is known as cricovocal ligament. So it is shown going like this inside the thyroid cartilage. It is shown here. It is attached to the cricoid cartilage and goes up. You see, this is the thyroid cartilage. It is going inside it and it is going to the free margin. This free margin is the vocal ligament. You see, it is going up to the free margin that is running between the vocal process of the arytenoid cartilage to the posterior aspect of the median angle of the thyroid cartilage. So this free margin is vocal cord and attached to the midway between the angle between the back of the angle of thyroid gland and its back it is into vocal process of arytenoid cartilage. So this is about the vocal ligament, cricothyroid membrane. It is going up like this, like a cone, like a tent. So this is also very elastic because vocal cord continuously have to flap and they have to come back to the normal location. This is mostly in elastic fibers. It contains a lot of it. So this membrane is also known as conus elasticus. This is all about the cricothyroid ligament. Let us talk about the cavity of the larynx. So the cavity of the larynx, due to the structures we have discussed now, it is divided into three parts. Let's move from above downwards. The line where we were talking about where actual cavity of the larynx start, this is known as inlet of the larynx. This is known as laryngeal inlet. It is more in a vertical position than in a horizontal position. It is like this on the opposite side, and it is communicating backwards to the laryngopharynx, and it is front. It is continuing with the backwards and upwards. It is anteriorly. It is made up of epiglottis. This whole part, that is the airy epiglottic fold, and on the back there is a fold running between the two arytenoid cartilages that is known as transverse fold between arytenoids. So this is the inlet of the larynx. So inlet can be seen when you are looking through the laryngoscope. This is how you will, as in up, you may have seen already when doing endotracheal intubations. When you're looking through the laryngoscope, you will be seeing this ring: epiglottis in front, airy epiglottic folds on sides, and the transverse interarytenoid ridge behind, and you will actually see two sets of nodules, two sets of dilatations on the posterior aspect of the aryepiglottic fold, and these are due to the cuneiform and the corniculate cartilages. This is how they will show as in real life, and between them, this red fleshy fold is the false vocal cord, and beneath them, the white portion that is just going medial to it, this is the true vocal cord vocal folds. And they in the blue line here, the laryngeal inlet has been shown. This is the laryngeal inlet. So it has further been divided into three parts. The part that starts from the laryngeal inlet, the part that starts from the laryngeal inlet and ends at the false vocal cord. This is known as vestibule. This is known as vestibule. The part above this ring, the part below this ring, between the laryngeal inlet and false vocal cord. This is the vestibule. Here, the vestibule will include this shaded area. This will be the vestibule. So here, you are actually looking at the vestibule up to this line. Everything above this thing is the vestibule. You are actually looking through the vestibule. Then there is laryngeal sinus or the ventricles. There were two sets of membranes, the one above that was the false vocal cords and the one below that was the true vocal cords. The one above was due to the quadrangular membrane, the one below that is due to the cricovocal membrane, and the space that is left between them, it is known as the ventricle or the sinus. So this space that is present between them, it actually outpouches and outside. This is the sinus, this is the ventricular sinus, and it not only extend outside, after pouching outside it does go anteriorly also. So this anterior extension of this is known as saccule, laryngeal saccule. This is the laryngeal saccule. It is the outpouching and it goes from the anterior aspect, and it is present between the, it goes as it goes forward, it is present between this quadrangular membrane, vestibular fold, and thyroid membrane and thyroid cartilage laterally, and the quadrangular membrane medially. It consists of a lot of mucosal glands that produce the secretion, and they trickle down over the vocal cords down to the trachea, and here it keeps the vocal cords lubricated. And here laryngeal ventricle is shown on the coronal section right here between the two vocal cords, true and false. Then there is infraglottic part. As we discussed earlier, this opening between the two vocal cords, this is known as glottis. This is known as glottis. So anything that is between them, between down below this and above the lower end of the cricoid cartilage, this whole area, this whole area, this is known as the infraglottic part of the larynx. In this picture, this is the lower end, this is the vocal cord, so this will be the infraglottic part. In this picture, it will be somewhat below this line. This is the infraglottic space. You are seeing the infraglottic space through the cut cricovocal membrane. This is the infraglottic part. Below the cricoid cartilage, you will enter into the trachea. This is about the membranes, this is about the parts, and then we are left with the glottis itself. This is the gap between the vocal cords, the rima glottis. For the 60% of the length, it is between the covered by on either side by the vocal ligaments. This 40% of the length, this on the either side, it is by the arytenoid cartilages. This is on the either side by the arytenoid cartilages. So this part is the intermembranous part, and this part is the intercartilaginous part. You don't have to actually remember the figures, but you just need to know that it's triangular in humans, and in males it is more in length as compared to females. and that's why the males this ligament is long. When it gets tight, it vibrates with less frequency. Males will have a deeper voice as compared to females. If you have ever played with an elastic like a guitar sling, you may have noticed that when the you may have if you have placed with a thread for a guitar string, if you take a bigger piece of thread, if you take a big piece of thread and you pluck it, you will have to maintain a higher pressure to get it to high pitch. But if it's a smaller one, just by pulling it a little, you will get a very high pitch. And that's something that happens here. In males, the thoracic cartilage is more anteriorly placed with respect to the arytenoid cartilages. This will allow the vocal cords to be more in length and they need more space. They will need more pressure to be tense, and that's why the males have a deeper voice. And this change you can actually see in the males going through puberty. Their voice suddenly changes as soon as the hormones kick in. I'm not going to discuss this in detail, but this is a slide regarding the type of epithelium that is covering each part. This is a basically topic of histology, but we were discussing larynx, so I said why not. Anterior surface of the epiglottis has an epithelium like the oral cavity, stratified squamous epithelium. The posterior surface, it's mostly like the respiratory system, pseudostratified ciliated columnar epithelium. But I have used part of. The transition between the stratified squamous and the pseudostratified occurs on the posterior surface. So the posterior surface of the epiglottis on the upper half has stratified squamous, on the lower half it has pseudostratified. The vestibule, the upper part that was pseudostratified, the vestibular fold has the same one. The vocal folds are covered with stratified squamous because they have to encounter a lot of trauma when they are vibrating. Do you know the audible pitch is the one that you can hear is 20,000 hertz, 20 megahertz. Uh, I think I'm doing something wrong. 20,000 hertz, the 20,000 vibration per second. So this we can do up to tens of thousands of vibrations per second. So this is an extreme physical trauma. To cover it, the vocal folds are changed into stratified squamous epithelium. And then on the top of it, vestibular folds are pseudostratified and vocal folds are stratified squamous. There is a transition as we go from pseudostratified to stratified squamous. This includes stratified columnar and cuboidal epithelium. And infraglottic space changes back to the pseudostratified ciliated columnar epithelium, and there is again a little transition phase as we move down. Muscles. That's the topic of the muscles that are moving the different components of the larynx. So these will be the different views we will be seeing. We'll be talking about the muscles as we see from them back, and we will be talking about the outside and the inside. Let's go through them one by one. The transverse arytenoid muscles. These are the muscles, as the name indicates, they are running between the two arytenoids transversely. They are attached to the posterior surface of the arytenoids, and when they contract, they bring the two arytenoid cartilages together. They help in the sliding movement. I will remove myself from this point. I can actually move myself here. Okay, so arytenoid cartilages, the sliding movement we talked about of the arytenoid cartilages can slide away or towards one another on the top of cricoid cartilages. So moving them together close to one another, it is done by the transverse arytenoid cartilages. And when it does that, it is actually directly closing the glottis. So it is the help that is tucking the vocal cords, bringing the vocal cords together to one another, and it is closing the glottis. The oblique arytenoid, these are the ones that are running here in this direction and this direction. They are running in the crisscross fashion, and from the muscular process of the arytenoid cartilage of one side to the apex of the arytenoid cartilage on the other side. These are pictures from the Grays and these are pictures from the Grants atlas. So these are doing the same function. They are bringing them closer to one another, closing the glottis and working as the adductor of the vocal cords. The thing that you have to look at it right here, this muscle is extending beyond the arytenoid cartilages. So this part that goes beyond the arytenoid cartilage is parallel to the aryepiglottic fold that is known as aryepiglottic part of the oblique arytenoid muscle. We will look at it shortly. It is basically the continuation of oblique arytenoid, and it, as it you can see, if it goes through the aryepiglottic fold, when it contracts, it will become straightened. When it will be straightened, so in short, it is narrowing the laryngeal inlet. It is the narrowing, it helps in narrowing the laryngeal inlet. It approximates the aryepiglottic folds. We have talked about the posterior. Now with the next is posterior cricoarytenoid. The name shows that it is attaching from the cricoid to the arytenoid cartilage. Its origin is from the posterior aspect of the cricoid cartilage. Its insertion is on the muscular process, the lateral process, this one, of the cricoid cartilage. When it contracts, the arytenoids along the vertical axis, they tilt like this. These are the movements we talked about earlier. So it helps rotate the arytenoid on the vertical axis. The vertical axis is shown by this red dot right here, and it twists like this. The anterior vocal processes, they go laterally, and the muscular process, as they're pulled, the anterior vocal processes, they go laterally, and we are doing now the abduction of the vocal cords, and it is leading to the opening of the vocal cords, opening of the glottis in a diamond shape. It is leading to the opening of the glottis in a diamond shape. So this is the posterior cricoarytenoid muscle. And this is the only muscle, that's the very important point. This is the only muscle that abducts the vocal cord. This abducts the vocal cord, that opens up the airway, and anything if it happens to this particular muscle, you are left with adducted vocal cords, and that is blockade of the pathway. Lateral cricoarytenoid are just doing the opposite. They are shown right here. They are arising from the cricoid cartilage of the lamina of the of the arch of the cricoid cartilage, and they are inserting on the muscular process. So this muscle, the previous one that we talked about, was approaching the muscular process from the back and pulling the muscular process back, and the articular process is laterally abducting. In the meanwhile, this is exactly opposite. It is approaching the muscular process from the front. So it, as it pulls the muscular process front, the vocal process, it goes medially. It goes medially. It closes the diamond. It will rotate the vocal process, vocal cord near one another. It will rotate the arytenoid cartilage along the vertical axis, and it will close the glottis. It is an adductor of the vocal cord. Then we are left with thyroarytenoid. It is starting from the thyroid cartilage and it is inserting in the arytenoid cartilage. So it is basically reducing the distance between the two. Here it is shown, it is basically running, on the roughly parallel to the cricovocal ligament, cricovocal membrane, and the uppermost part of this thyroarytenoid muscle is known as vocalis muscle. So it is running between the thyroid cartilage in front and the arytenoid cartilage in the back, and the topmost process where it is attached to the thyroid cartilage here and the arytenoid cartilage here, it is the vocalis muscle. So when it contracts, it reduces the distance between the thyroid cartilage in front and the arytenoid cartilage in the back. In the meanwhile, it is relieving the tension from the vocal cord. You can see here, it is attaching to the thyroid cartilage in front and arytenoid cartilage in the back, and when it is contracting, it will reduce the distance between the two, meanwhile reducing the tension of the vocal cord. So this is vocalis muscle. This is the vocalis part that is purely parallel to the vocal cord, and then there is a part that is expanded up along the aryepiglottic fold and along the aryepiglottic fold that goes to the this free margin. This part is more better known as thyroepiglottic part of the this muscle, sometimes known as a separate muscle, thyroepiglottic muscle. It is attaching to the aryepiglottic fold, and they will pull the aryepiglottic fold towards the thyroid cartilage. In other words, it will be opening the laryngeal inlet. It will be getting the thyroid cartilage laterally. As you can see, the running of these all these fibers is across this saccule, the middle cavity. When these muscles contract, the saccule is compressed, and the secretions that have been produced to them, they go and supply over the vocal cords. This brings us to the thyrocricothyroid muscle. The names indicate it is originating from the cricoid cartilage below, and it is attaching to the thyroid cartilage above. When it contracts, it helps tilt the thyroid cartilage in front. So the dotted line was the previous position, the solid line is the new position. It tilts the thyroid cartilage to the front, and as it tilts, the vocal cords are stretched. The vocal cords are stretched, the vocal cords are thin, and you're able to thin your voice. You can see when you're talking, you can actually make your voice thinner. When you're making your voice thinner, what you're doing is you're pulling the thyroid cartilage in front, increasing the distance of the anterior angle from the arytenoid cartilage, increasing the tension on the vocal cords. So that's it. That's all the functions of all the muscles of the vocal cords. I have been using the pictures from the Grays and the Grant's Atlas. The one that were on the top were from the Grays, the one on the bottom were the Grants, and the and this picture, this set of muscles, this picture is from the Netter's Atlas, and this table from the top, it is from the Snell's Atlas. All the muscles, origin, insertion, and functions are discussed. And the one thing that you can see, there is only one nerve muscle that has a different set of nerve, that is the external laryngeal nerve. All the rest of them are supplied by the all the rest of them are supplied by the recurrent laryngeal nerve. So let's get back to it. So these are the summary slides again from the Snell's. So these are talking about the elevators of the larynx, the pressure of the larynx. The elevators include all the suprahead muscles, and among the infrahead muscles, the thyroid muscles, the digastric, stylohead, mylohyoid, gynohead, and the elevators of the pharynx include elevate the larynx indirectly. Stylopharynges, salpingopharynges, palatopharynges. You will see them in the pharynx lectures. And the depressor includes 3 out of the 4 infrahead muscles. These are the sternohyoid, sternothyroid, and the omohyoid muscle. When talking about the narrowing of the inlet, we have talked about this extensions of the oblique part of thyroarytenoid, aryepiglottic part. This is the one that is responsible for narrowing of the inlet. For extension of the inlet, we were talking about this muscle, the thyroepiglottic part of the thyroarytenoid muscle. For the vocal cords, we talked about the tension and relaxation. The tension was due to this muscle, cricothyroid, moving the thyroid cartilage anteriorly. The relaxation was due to this muscle, the vocalis, that was reducing the distance between the two. The adduction of the vocal cords was due to the adduction of the vocal cords was due to the lateral cricoarytenoid muscles. The lateral cricoarytenoid muscles twisting the turning the vocal cord arytenoid cartilages medially. Abduction was posterior cricoarytenoids, abducting it like this, and approximation of the arytenoid cartilages itself, they are occurring due to the transverse arytenoid muscles. Let's talk about a few of the other things. There is swallowing. When we swallow, the food does not go into the larynx usually in a normal person. The food does not go into the larynx because their aryepiglottic folds have a sphincter functions. The aryepiglottic fold come together, narrow, become narrow, and they strong. They close the fold. The other thing is elevation of the larynx. When we are doing the swallowing, the whole of the pharynx is pulled up, and along with it, the larynx is pulled up. When the larynx is pulled up, the epiglottis here, there is a tongue present right here. When the larynx go up, the tongue is pressed against the larynx, is the epiglottis of the larynx is pressed against the tongue, and it turns like this. So it acts like a lid covering a lot of the opening, but it is not a perfect seal. And the perfection and the most important thing is the closing of the vocal cords. The closing of the vocal cord is the most important one. The vocal cords attach so much close to one another that they don't allow a drop to pass through. And that's why when you're swallowing, due to the elevation of the larynx, due to the constriction of the arytenoid folds, the food usually go through this pathway, through the piriform fossa. Some may jump over it, and during the jumping, if somewhat go inside, it is stopped by the arytenoid cartilages. It is stopped by the vocal cords. You may have done it in your, you may do it now, or you were doing in your childhood, that when you were drinking a soda, Pepsi or Coke, if you just don't swallow, resist a little, and let the Pepsi to go to the back of your throat, it actually goes and touches the vocal cords. That's the sharp signal, that's the sharp sensation you feel. That's the swallowing. Phonation, that is a production of the sound. Phonation consists of the pitch, that is the thinness and thickness, deep sound or not. Intensity mean loud sound, and low sound. Quality and articulation. Quality means, um, even if my like this, I'm talking like this, but if I close my nose, you will feel a difference in the quality of my sound. This is the nasal quality of timbre. So this is the quality. The pitch, it is usually due to the frequency change. The denser the vocal cords, the thinner, the higher the voice will be. The relaxed the vocal cords are, deeper the voice will be. The intensity is by the amount of air that is passing through. If you get a lot of air, the vocal cords will flap a lot and the voice will become high. But if you push some sound, the vocal cords will flap with a less amplitude. So pitch is due to the different frequency. The intensity is due to the higher amplitude. When you are talking loud, the vocal cords are doing like this, and when you're talking slow, the vocal cords are doing like this. When you're talking high pitch, the vocal cords are doing like this. When you're doing low pitch, the vocal cords are doing like this. The quality, it depends upon the chambers above. It depends upon the sizes and the functioning of the paranasal sinuses. It depends upon all the chambers, the vestibule, the larynx, the oral cavity, the nasal cavity. Your voice drastically change when you have a flu because a lot of your chambers has a fluid then. The articulation, the formation of the words, it is due to the movement of the muscles of the mouth, the lip, the tongue, and it's touching on inside. On when we are whispering, when we talk like this, we are actually closing the vocal cords and only separating the arytenoid cartilage. So the sound exits from the back. The whispering is very wasteful for the air. Try to count from 1 to 100 in one breath while whispering, and try to count from 1 to 100 while speaking normally. You will get further when you are talking normally because the slit is closer, the slit is more close, near to the closing point in the phonation. In the whispering, a lot of air is lost. You can't whisper alone. The whisper ends your breath very quickly. Then there is muscular efforts. We have talked about it in the, we will talk about it in the thorax lectures. When you are lifting a lot of things, when you're lifting a heavy weight, you produce a grunting sound. Like if I try to lift the table in front of me, it's like this is the grunting sound. Why it's doing like this? Because when we are lifting anything heavy, our vertebral column tend to collapse on itself in the anterior aspect. It needs every possible support it can get. A lot of it is coming from the muscles of the back, but our diaphragm helps in such a way that diaphragm goes down all the way down. It, you take in long inspiration, and then the vocal cords play a role and they tightly oppose with one another. So the lot of air that has gone inside the lungs, it is trapped. When the air is trapped, there is a high pressure in the thorax. The diaphragm has pushed down on the abdominal cavity. There is high pressure in the abdomen. The abdominal muscles are contracting and they are increasing the pressure in the abdominal cavity. Furthermore, so this acts like a football in front of you. You can't bend your torso because of so much pressure inside. It's like a balloon. When it's near empty, you can fold it in all directions, but when it's tight and full, it is difficult to bend it. Why? So you act like a balloon with air trapped inside, and the glottis come. And the glottis is trying so hard, the vocal cords are trying so hard to close it, and the little sound that exit, it comes out like a grunt. It is basically a little air leaking through the closed vocal cords. And this closure of the vocal cords help you in maintaining your body posture, in lifting the heavy things. This closing help you in coughing. You close it, trap your air inside, close it, build the pressure, and then open it suddenly, and then the cough comes out. The same things happen with a sneeze, and the same thing happens when you are going to the washroom. You are doing defecating or micturating, vocal cords are closed and you put pressure, and it helps in overall raising the abdominal pressure because as the diaphragm comes down, if the vocal cord is open totally and you exert in the washroom, the air will come out and the pressure won't be transmitted down to the abdominal viscera. So that is why the person who have a permanent tracheostomy tube, the person who cannot close their vocal cords, they tend to get more constipated. They are advised to take care of it. They are advised to look for it, that they don't get any constipation. So that brings us to the closing remarks. We have to discuss the nerves and the blood supply. The arterial supply is from the two sources. The upper end, it is supplied by the superior laryngeal branch of the superior thyroid artery. The superior laryngeal branch, it penetrates this thyroid membrane. It penetrates the thyroid membrane, and it goes and supply above the vocal cords. The inferior below the vocal cords, this infrathyroid artery, the branch of the costocervical trunk we have discussed in our head and neck lectures, and they go up to the thyroid gland. The superior one, it is related to the superior laryngeal nerve, a branch of the a branch of the vagus nerve, and the inferior one, it is related to the recurrent laryngeal nerve. So during thyroidectomies, when these arteries are to be ligated, superior and inferior thyroid arteries, there is a possibility that if the surgeon is not careful, it will lead to the ligation of the related nerves. So, if you have witnessed a thyroid surgery in person, you might know that the anesthetist makes witnesses before start of the thyroid surgery. He shows, see, the vocal cords are functioning, and then after the thyroid surgery, the surgeon makes the anesthetist a witness, see, both of the vocal cords are functioning. So no one can get some blame that the surgeon has damaged the nerve or the anesthetist has done some local damage in the larynx. So they make each other witness before and after the surgery. The venous drainage, it's just like the thyroid gland. The upper part is drained above the vocal cords to the suprathyroid superior thyroid veins, and the inferior part is majorly drained by the inferior thyroid veins. The larynx, again same. The upper one, the supraglottic, the upper to the vocal cords, it's going to the upper deep cervical lymph nodes. Below, it is going with the deepest to the lower deep cervical nodes. Some of them goes to the nodes in front or the lateral aspect of the larynx known as prelaryngeal or paralaryngeal nodes. The innervation. The nerves, all of the motor supply, all of the muscles are supplied by recurrent laryngeal nerve except one muscle, that is the cricothyroid muscle. Sensory supply, the upper half of the larynx above the vocal cords, it is supplied by this nerve, the branch of the superior laryngeal nerve that is going inside. So it is the internal laryngeal nerve. And the external one was that was going to supply the cricothyroid muscle. And the nerve that is supplying all of the lower part, that is the recurrent laryngeal nerve. The recurrent laryngeal nerve on the right side was coming after turning upside below the right subclavian. On the left side, it is coming after turning upside below the arch of aorta and ligamentum arteriosum. So the right recurrent laryngeal nerve has a shorter pathway than the left one, and the left one is the one that is coming from the thorax. So for tumors and surgeries, the left recurrent laryngeal nerve is more prone to damage. While closing, let's talk a little about the palsies. If there is a recurrent laryngeal nerve palsy, complete palsy, the vocal cord usually get in a cadaveric position. In the vocal, the midline position is the median, it is paramedian position. It does not move at all. It does not adduct or abduct because the only muscle right now function is cricothyroid, that is actually the tensor of the vocal cord. So it does not move at all. So the respiratory problem are rare actually because the problem usually arises when you cannot close your glottis. When you cannot close your glottis, every time you drink something, something will go inside the trachea. But it does not usually pose a problem because the normal vocal cord has a tendency to compensate by crossing the midline and reaching the other vocal cords on its side. So this is why it acts. If there is a partial injury, the partial injury, the Simmons law says that abductor fibers are affected first. This law says that in most of the nerves, the abductor fibers are on the outside. So when there is an injury from the outside, the abductor fibers are more likely to be damaged. If there is a partial injury, abductor fibers are affected, then the vocal cord will be in more median position. It will more near to the midline. It will be more prone to close the glottis unnecessarily, but again, due to the healthy other side vocal cord, you increase and decrease the distance as you please. If there is a bilateral recurrent laryngeal nerve palsy, both of the vocal cords remain in cadaveric position. The different position are shown here, the median, paramedian, intermediate, abduction. So it remains in this intermediate cadaveric position. Both of the vocal cords remain that, and the V-shaped glottis remain open. So that's the point. You cannot produce a sound. The sound cannot be produced because to produce a sound, the vocal cords have to be brought closer. This is the sound that the person will be able to produce. The strider will be produced a little because you cannot, when actually you are taking deep breaths, the vocal cords are abducting a little. You cannot abduct either. You cannot adduct, you cannot abduct. And the worst situation, the worst effect of this injury is that the glottis is not closed. It cannot seal the airway against the food and drink. The person is hampered for life from drinking water. As soon as a person drinks water, it goes into the trachea. So this is an indication for tracheostomy. This person cannot live a long life like this. So what we do is an opening is created here in the trachea, and the upper end of the larynx is closed so that the breathing continues from here, and the food intake can be continued from there. So tracheostomy it's indicated, and this is not due to the closure of the airway. This is due to the failure of intake of food. Partial recurrent nerve palsy. If the palsy is partial, abductor muscle is more likely to be damaged due to Simmons law. The abductor fibers were outside. they will be damaged. If the partial lesion is on the one side, one vocal cord will come to the median position, but the other vocal cord will compensate by getting away or close it. But if both of the vocal cords, both of the recurrent laryngeal nerves get partial palsies, partial injuries, abduction for both of the vocal cord will be lost and both the vocal cords will come to the midline. And this is an acute condition. You have to do tracheostomy immediately because the vocal cords are closed, stuck, it will close and the airway has been blocked. So you have to act immediately to open another airway, that will be tracheostomy right here. And there is an if there is an paralysis, if we're talking about the recurrent laryngeal nerves, they are usually damaged when ligating the inferior thyroid artery. That is one of the most important cause. But other structures, other injuries along the way that will be traumatic or due to tumors, they may lead to the recurrent laryngeal nerve palsies. This brings us to the end to the external laryngeal nerve. This only affects the tensing of the vocal cord. Cricothyroid membrane does not work, and that lead to the loose vocal cord that are not under tension, that leads to the deepening of sound, hoarseness of sound. A person is unable to produce high pitch sound, and when you're looking through laryngoscope, it is not as straight the vocal cord as it should be. So these are the different injuries we discussed. So that's it. We have come to the most of it. These are the resources we have used. So thank you so much for listening to me. If you have any questions, suggestion, or feedback, please do mention in the comments. We'll get back to you with all the answers we can. Keep tuned with us for the future videos. We will be completing our head and neck session in the near future. Then we will move on to the our other aspects. And please follow our channel to look for the up to date and extensively discuss videos regarding anatomy and physiology. Thank you so much. See you next time, inshallah. Allah Hafiz. Good night.